This is your lecture on bowel disorder drugs. I'm sure all of you in this course are very familiar with diarrhea and what that is. We would describe it as frequent liquid stools, and what I included in this slide is something that becoming a nurse, you will live and breathe the Bristol stool chart. We actually document our stools based on the Bristol stool chart, and it goes anywhere from a type 1 all the way through type 7. So if you have anything from type 6 to type 7, that would be considered diarrhea. And it's great because it provides you a great picture of what that stool will look like. So it can be mild to severe, and diarrhea can be very problematic because it can also cause dehydration and electrolyte imbalances. If you are having diarrhea, you really should avoid foods that are going to be high in fat and milk products. You really want to stick to a brat diet: bananas, rice, applesauce, and toast. And diarrhea can be caused from quite a few different things: toxins, spicy food alone, drug reactions, abusing laxatives, fecal impaction. Sometimes people think that they're constipated, and what ends up happening is there's stool that leaks around it. So now they think they're having diarrhea. Well, it's actually the stool that's impacted that's causing the other stool to leak around it. So you really have impaction as your main problem. It's not diarrhea. And then stress and anxiety can also cause diarrhea. There is also malabsorption syndrome, inflammatory bowel disease, bacteria. Most commonly are E. coli and salmonella, as well as viruses, our parvovirus and our rotavirus. As I was mentioning earlier, you really want to stick to a brat diet: your bananas, rice, applesauce, toast. You really want to avoid those high fat foods or your dairy. It's good to also make sure that you identify or do your best to identify the cause of your diarrhea before you start taking a medication. So you want to start to try non-pharmacologic measures as best as possible. Another reason being is if it's due to either a virus, toxin, bacteria, and you take an antidiarrheal, you are prolonging that bacteria or the virus in your system even longer. So it's really important that you identify that cause first. It's good to just try clear liquids first to try to maintain your hydration, but if it's severe enough, you may need IV fluids to hydrate, because it can be pretty severe if you're not taking in fluids and you're starting to have a shift in your electrolytes. Now we're moving into our first category of our antidiarrheals. The first category are adsorbents. Our prototype drug is bismuth subsalicylate. When you hear that name, subsalicylate, what does that make you think of? If you're saying with the word salicylate, aspirin, you would be correct. This drug, also known as Pepto-Bismol. Most people are not aware that there is aspirin in Pepto-Bismol. So, coming from prior knowledge of what we learned about in previous weeks, majority of the time, at least I know when I was a young kid, I had a stomach ache, complained of my tummy hurting. My mom would give me Pepto-Bismol. And as a child, what do we have to worry about? Well, if you're thinking Reye's syndrome, you're absolutely right. So, a lot of things to learn about these medications that a lot of people do not know, and kind of going back to what we talked about week 1 of why it's so important that we don't just take over the counter medications without really understanding what we're taking and why, because these could be very problematic. So, going a little bit back now as to what bismuth subsalicylate does, it acts as a coating to the wall of the GI tract. So, it's going to bind to that bacteria or the toxins to absorbent surfaces for eliminating from the body through the stool. Now, again, it does contain aspirin, so we cannot give this to children that have a viral infection because of the risk of Reye's syndrome. It can also, and by can pretty much 9 out of 10 times, will cause your stool to turn a dark brown, and it can be mistaken for a GI bleed. So it's very important that we make sure we rule that out and also educate our patients so that they don't become concerned that their stool has changed. It's also very risky if you have a patient that is a risk of bleeding because it is an aspirin product. So especially your patients that are already on anticoagulants, they should not be taking this because they're going to be at an even higher risk of bleeding. This does also pose a risk of salicylate toxicity. So you might think this is an over the counter medication, it's harmless. I'm just going to take the whole bottle. My stomach's hurting. I don't feel good without thinking the consequences. And you could get salicylate toxicity, which, if you can remember back, which feels like forever ago, how would you know? Ringing in your ears. So if your patients are taking Pepto Bismol and they start complaining of ringing in their ears, you should be thinking salicylate toxicity. Are you sick of hearing about anticholinergics yet? As you can see, they are used in so many different categories and for so many different reasons. We can use this for patients that do have diarrhea to slow peristalsis through reducing the rhythmic contractions and smooth muscle tone of the GI tract. It does have a drying effect as well, so it will also reduce gastric secretions. We could combine it with absorbents and opiates, so it may not just be by itself, but it is only going to be available by prescription. So our prototype is belladonna alkaloid and those combinations. We also call them Donatal. So we use this to treat diarrhea. It is contraindicated in your narrow angle glaucoma, anybody with a GI obstruction, myasthenia gravis, a paralytic ileus, and basically what that means, think paralyzed ileus. It's not moving forward, so there are no peristaltic contractions. And we could also have problems with a toxic megacolon. So our Donatal is going to be mixed with 4 alkaloids, our atropine, icosapine, phenobarbital, and scopolamine. It is prepared either as an elixir, tablet, or extended release, and it's a variation depending on what exactly it is of pregnancy category C to X. Keep in mind your other anticholinergic effects we need to be mindful of. Can't see, can't spit, can't pee, can't poop. So obviously we're taking this for the pooping factor, but the patient can't spit, they have dry mucous membranes, we need to educate them, might need to use some lozenges, drink some water, which would also be helpful with the dehydration and to hopefully slow down those bowels, but also urinary retention. So if you have a patient that's already having issues with urinary retention, we need to watch their urine output very closely. Now moving into using opiates. Our prototype medication would be diphenoxylate with atropine. It is a synthetic opiate agonist structurally related to meperidine, also known as Demerol. It acts on the smooth muscle of the intestinal tract to inhibit GI motility and excessive GI propulsion. There is going to be little analgesic activity. You do still have a risk of abuse and dependence because it is an opiate. However, something else to consider is patients on the other side of things. If they are overusing opiates, it can cause constipation. So you can give this medication because somebody is having excessive diarrhea, or you need to be concerned that you're giving an opiate and it can cause constipation. So we could also combine this with atropine to discourage use for recreational use of opiates. If it is taken in high doses, there will be extreme anticholinergic effects if it has atropine within it. It is contraindicated if patients are having diarrhea that is associated with pseudomembranous colitis and toxigenic bacteria. And this is only going to be available PO. Another medication we utilize, loperamide or Imodium AD. You'll see this commonly over the counter. See it if you go to CVS, Target, Walgreens. It is a synthetic antidiarrheal that's very similar to diphenoxylate. It does inhibit both peristalsis in the intestinal wall and intestinal secretion to decrease the number of stools and water content. Despite it being an opiate, there has not been an issue with physical dependence. It is the only antidiarrheal that's available over the counter, and it is contraindicated in patients that have severe ulcerative colitis, pseudomembranous colitis, or acute diarrhea associated with E. coli. Now let's talk just a little bit about probiotics. Probiotics are going to suppress growth of diarrhea-causing bacteria. It will then help to reestablish the flora residing in the intestine. Commonly, we'll use cultures of lactobacillus. It's also known as our intestinal flora modifiers. Typical benefits are suppression, growth or invasion by pathogenic bacteria, improvement in intestinal barrier function, modulation of the immune system, and modulation of pain perception. So our prototype you'll commonly see, lactobacillus. Lactobacillus acidophilus or BASID and Lactobacillus CG culturelle, you see these very commonly over the counter, are acid-producing bacteria. They're normal inhabitants of our GI tracts, and through fermentation of carbohydrates, it does create an unfavorable environment for the overgrowth of harmful fungi and bacteria. So typically we utilize it for diarrhea caused by antibiotic therapy. It's also great preventative or prophylactic therapy. So if you have somebody, especially inpatient, that's on multiple antibiotics, we will start them on probiotics as soon as those antibiotics are started. So typically what we'll do is even if the patient is intubated and sedated on a ventilator, hopefully they'll have a nasogastric tube and we can put the probiotics down the nasogastric tube. So that's something that we will commonly do to hopefully prevent something from occurring. But should it already occur, we still would utilize probiotics. For nursing implications in patient education, we should always assess the contributing factors to the diarrhea and if they have recent travel. Always do our baseline labs. We're really looking at our electrolytes to make sure that they're not too altered. Looking at our baseline vital signs, and we always want to do a thorough GI assessment. That's looking at our bowel sounds, appearance of the abdomen, when was the last bowel movement, what is the frequency, and what is the consistency of the stool. The patient should also be taking these medications exactly as prescribed due to the risk for some of these being habit forming. We do also want to educate that constipation could result. So we need to make sure that we're trending the bowel movements, and if they're starting to now get to the point where you're having less, maybe we need to pull back and not take as many doses. Again, with the dietary recommendations, not ingesting fried foods or milk until your diarrhea has ceased, and taking in as many fluids as possible. Water is always going to be the best, and it would be ideal to avoid red liquids or foods like jellos, cranberry juice, etc., because it could mimic bleeding. So we wouldn't know if it's either blood in your stool or if it's from what you consumed. Now we're looking at the opposite side of it, using laxatives. So laxatives we're going to use to treat constipation. Constipation is a disorder of movement through the colon and the rectum, and it's caused by either diseases or drugs. Usually the span between ingestion and defecation, so defecation is having a bowel movement, is 24 to 36 hours. Bowel movements, again, also known as defecation, is a reflux that involves smooth and skeletal muscles. So you have feces that enters the rectum that stimulates mass peristaltic movement, and that results in a bowel movement. Treating constipation is going to vary between every patient. You may have surgical and you may have non-surgical interventions. Non-surgical would be dietary changes, behavioral, and pharmacologic. Laxatives, unfortunately, are one of the most misused medications, and if it is abused and used long-term, it could lead to dependence and even damage to the bowels. It really is only for short-term use. This is not meant to be something that's taken daily. We do need to assess the factors for constipation and why that's occurring. Medications could be a factor, fecal impaction, lack of exercise, bowel obstruction, chronic laxative use, neurologic disorders, ignoring the urge to defecate, and that happens a lot in children, insufficient water intake, and poor dietary habits. We should also look at utilizing non-pharmacologic measures. That would include diets that are high in fiber, increasing our fluid intake, incorporating exercise, and making sure we have a routine for our bowel habits. Now diving into the medications we would utilize, the first category are the bulk-forming laxatives. And these are going to act similar to the fiber natural consumed in our diets. It's going to then absorb water into our intestine to increase the bulk and distend our bowels. This then initiates reflex bowel activity and promotes a bowel movement. It's composed of water-retaining natural and synthetic cellulose derivatives. It works to produce normal form stools, and the action is limited to the GI tract. So we do have a smaller incidence of systemic effects, which is really good. We do need to encourage taking this with at least 8 ounces of water to prevent esophageal obstructions when you're consuming and or fecal impaction. It can be purchased over the counter and should be considered the safest laxatives. They are the only laxatives that we can consider utilizing more long term. Our first drug that we'll be talking about, methyl cellulose, also known as Citracel. This is a synthetic bulk forming laxative working to attract water into the intestine, to absorb excess water into the stool, to stimulate the intestine and increase peristalsis. It is contraindicated in an intestinal obstruction and hepatitis. It does come as a powder that has 2 grams of fiber per tablespoon. So again, needing to mix that in water, at least 8 ounces, and making sure that it doesn't coagulate because it can get really thick if you don't mix it well. And then we have psyllium or metamucil. This is a natural bulk forming laxative that's obtained from the dried seed Plantago psyllium. It has a lot of similar characteristics to methyl cellulose. It's contraindicated with abdominal pain, nausea, and vomiting. And it can also come as wafers or in a powder form. Next, we have emollient laxatives. These directly lubricate the stool and the intestine to prevent water from moving out of the intestines to soften and expand the stool. It also works by lowering the surface tension of the fluids to allow more water and fat to be absorbed into the stool and the intestines. Our prototype drug, one that you'll very commonly see, docusate sodium or calcium, also known as Colace. This is used to treat constipation, soften fecal impaction, prevent opioid-induced constipation, but it doesn't cause the patient to actually defecate, it only softens the stool. It is contraindicated with an intestinal obstruction, fecal impaction, or nausea and vomiting. Next, we have mineral oil. Mineral oil is going to ease the passage of stool by lubricating the intestines and preventing water from escaping the stool. It is the only lubricant laxative in our emollient category. It has a mixture of hydrocarbons that is derived from petroleum. It is commonly used to treat constipation associated with hard stools or fecal impaction. It is contraindicated in patients with intestinal obstruction, abdominal pain, nausea, and vomiting. And we do have this available as either an enema or PO. Next, we're moving into our hyperosmotic laxatives. These relieve constipation by increasing water content of the feces, leading to distension, peristalsis, and then defecation. Site of action is limited to the large intestine. Most commonly, we use this to manage constipation and evacuating bowels before a diagnostic and surgical procedure. Our first drug is glycerin. This promotes a bowel movement through increasing osmotic pressure, drawing fluid into the colon. It's very mild and can also be used in children. It is available as a rectal solution and a suppository. Our next medication, lactulose. This is a synthetic derivative of natural sugar lactose. It is not digested in the stomach or absorbed in the small bowel, rather passes unchanged into the large intestine where it's metabolized. Colonic bacteria then digest lactulose to produce lactic acid, formic acid, and acetic acid. This then creates a hyperosmotic environment to draw water into the colon and produce a laxative effect. But another reason we utilize this medication and pretty frequently in the acute care setting is to reduce ammonia levels because it converts ammonia to ammonium. Ammonium is a water-soluble cation trapped in the intestines. It can't be reabsorbed into systemic circulation, so it helps reduce serum ammonia levels in our patients that have hepatic encephalopathy, high ammonia levels. Those can be extremely dangerous. So we want to make sure, especially in our patients that have alcohol use disorder, we trend our ammonia levels, and if they're elevated or too high, then we will give lactulose. You can expect pretty large bowel movements to come from this. We can give this as an oral solution. Does not taste very well. I guess I shouldn't say that because I've never had it myself, but anytime I've given it to a patient, they've told me that, oh, this is not good. But it can also be given as a retention enema. So you would instill it, then you would, if the patient is able to follow direction, try to hold that in as long as they can to produce the best effect. So that is two different ways that we could use that. Another drug we use, polyethylene glycol 3350 or PEG 3350. This is most commonly given before diagnostic procedures. You'll hear this also called go lightly, which is kind of funny because you do not go lightly at all. This drug is not commonly given anymore because it's mixed in a solution with 4 liters. So it's pretty unrealistic to expect, especially you have a patient, maybe let's say in their 70s, 80s, or even with heart failure, to consume 4 liters. It's near impossible. So another option, I actually had called a physician one night and I said, I've got an 85-year-old patient. She can't consume 4 liters of this. Can we do another medication before her procedure tomorrow? And he said, well, if she can't drink it, put it in an NG tube and put it down that way. Which, if you have an awake and alert patient and they have no problem swallowing, you're not going to put a nasogastric tube in just to give them that medication. It's not realistic. So that was a challenging communication experience, I'll call it, because it's not realistic. So nowadays, if you have conversations with gastroenterologists, they're changing up what they're doing and they're not just giving the 4 liters because it's not realistic for a majority of people to consume that. So you'll still see this. It's still made, but it's not as commonly used as it was before. Next, we have our saline laxatives. This is going to consist of various magnesium or sodium salts. That then increases the osmotic pressure to draw water into the colon, which then produces watery stool within 3 to 6 hours of ingesting. The prototype we will look at is magnesium salts. These are over-the-counter products that are most commonly used to evacuate bowels for endoscopic exams or removing poisons from the GI tract. They will be contraindicated in patients with renal insufficiency because it can lead to hypermagnesemia, abdominal pain, nausea, vomiting, any obstruction, an acute surgical abdomen, and rectal bleeding. Some exact drug examples are going to be magnesium citrate, citroma, or magnesium hydroxide, which is also known as Phillips milk of magnesia. We also have sodium laxatives, and those are our Fleet's enema, and we do use those pretty commonly in the acute care setting. And lastly, we have our stimulant laxatives. This is going to induce intestinal peristalsis. Site of action is going to be the entire GI tract. The action of the stimulant laxative is going to be proportional to its dose. This is the class of laxatives most likely to cause dependence. Our prototype is bisacodyl or Dulcolax. This is available over the counter, and it is the most commonly used stimulant laxative. It can come as an oral tablet or a rectal suppository. We use it to manage constipation or bowel evacuation before an endoscopic exam or surgery. We also utilize senna, also known as senna-cot. This is obtained from dried leaves of Cassia acutifolia plant that's used for acute relief of constipation or bowel evacuation before an endoscopic exam or surgery. This drug likely will induce abdominal pain because of the cramping, and you'll see a bowel movement within 6 to 12 hours. It does come as a tablet, syrup, or granules, and it can also be made into Senna-Cot S, and that includes both senna and docusate sodium, which is cholase. For nursing implications in patient education, we should assess the history of constipation as well as the potential causes. We should do a baseline assessment of our vitals just for future comparison. Do baseline labs, especially focusing on our electrolytes. We should be looking at our intake and output and do a thorough bowel assessment. We should always make sure that we are asking our patients that come in, regardless if they are suffering from a bowel problem or not, when their last bowel movement was. This is something I have seen so commonly in my career, that the bowels are the first to be forgotten about. And sometimes I'll get a report and the nurse isn't sure the last bowel movement. I do an assessment and it's been 5 days. I don't know about you, but 5 days without a bowel movement does not sound okay to me. So I like to ask my patients, what is your normal bowel history. Everybody is different. Some people do go every day and some don't. So, the best way to approach that, ask your patient, what is normal for you? We need to make sure that if it's not being addressed, that we do start a bowel regimen because constipation can lead to a lot of problems and the patients are already in the hospital. We don't need to add more problems onto their plate. So, always remember to address the bowels and ask when the last bowel movement was. We should also educate our patients they should increase their water intake to decrease those dry, hard stools. Dry, hard stools can also be extremely problematic. If the stool is hard enough, it can actually cut the inside of your rectum and cause a fissure. If that is open and doesn't heal, that could also lead to a lot of problems. And not to mention, it's painful. So if your patient is complaining of some blood from their rectum, it could be from dry, hard stools. We should also encourage intake of fiber, your grains, fruits, and bran. We should also educate our patients to take these medications exactly as directed because of the risk of dependency. We also shouldn't take these within an hour of any other medication because if you're increasing your peristalsis and have taken a medication relatively soon, you could potentially be altering the metabolism of that medication. We should also recommend our patients take this in the morning. Do not take a laxative at night because you're going to be awake all night and you're not going to get any sleep and you're going to feel horrible the next day.